Business as usual, and the radio rails out its shrill call. You go to answer it. The medic online has little information. His partner is just getting vitals now. He's trying to stick to the standard operating procedure, but his voice gives him away. They are at a major house fire with 2 known adult casualties. They're just calling to tell you that they're bringing in 3 children under the age of maybe 12. The rescue unit just discovered another badly burned adult there as well. All you can surmise from the call is that the children are critical. 1, they're getting ready to bag now. They'll be here in 7 minutes. What's your next move?
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Taking care of anyone with a major burn, adult or child, can be intense. This is where your critical thinking and critical care skills are put to the test. You have to be in the moment and meticulous, but also scour the past for any helpful clues while you're looking to the future, trying to mitigate all of the dangerous multi-organ system failures that are right around the corner. Your patients arrive all at once. One girl looks to be about 3 or 4. She's wailing, in pain, or just frightened, or both, and appears to have multiple extremities affected. You send her to the resuscitation room as you're receiving the second. He is about kindergarten age, coughing, his skin red and black with soot. He isn't as loud as the girl, and that worries you. The third patient is a very scared toddler, quiet but quick to scream when you make eye contact. Who takes priority? It's you and 3 nurses. This is where the squeaky wheel gets the grease, just not right now. Let's take a look at the coughing boy with soot, the one who's not really complaining. He's confused. His face and nares are slightly singed. Right in front of you, his breathing gets noisier. You know that this is the time. You pre-oxygenate while you set up your airway equipment, you hang fluids, sedate, paralyze, and thank you God that you got that tube in. It looks like you stuck a straw through a hot dog. The boy went from no respiratory distress to an edematous airway in what seems like an instant. You get him squared away, sedated with analgesia and fluid resuscitation. Now to the scared toddler who didn't like the look of you. She amazes you now with how calm she is. After some IV analgesia, she's lovingly looking into her nurse's eyes as her nurse strokes her hair. She needs fluids too, but how much? And what is the extent of her burn? What needs to happen now? You start your full assessment. Later, you're able to get back to the loud, wild child, the 3-year-old. She's burned almost as badly as the toddler, except there appears to be bruising on the flank, in addition to her burns. The situation I just put you in is not typical. About 2/3 of burns in small children, those under 4 years of age, are scalding injuries. A hot liquid spills on them. Microwaved liquids are often the culprit, since we sometimes overshoot cooking times. Hot ramen, need I say more? Man, ramen, trampolines, bouncy houses, am I right? Scalding injuries are common in children, also because of hot water in bathrooms. In fact, scalding in the bath is often worse than food scalding. Food is a splatter, while hot water in the bathtub is often a submersion. Even if the child protests immediately and the adult gets him out immediately, more surface area is harmed all at once. Electrical outlets and cords are much less common in children, and open fires, or in this case, a massive house fire, thankfully are not as common, but we need to be ready. Remember that a burn is a trauma, and with trauma, multi-trauma is the norm. Your third patient, the loud 3-year-old, has what appears to be trauma to her flank in addition to her burns. Who knows what fell on her or what she fell on? Of course, once we open our minds to the possibility of trauma, non-accidental causes come to mind as well. We have to think of these major burn patients as multi-system trauma patients, except the trauma that you see from a fall or from a motor vehicle collision, the damage is usually done by the time you see them. You're just trying to deal with the aftermath. In burns, the injury is ongoing. They're still cooking, just more slowly. Scalding liquids are bad, but grease burns are worser. Why? The grease sticks and insulates. The core area of necrosis is gone. It's toast already. And there also is that concentric surrounding area of stasis that's at risk for further tissue damage. That is then surrounded by a less injured area of hyperemia. The middle ring, the area of stasis, that is still salvageable if we act quickly. And this is how we tie in local wound care and attention to the apparent skin injury in front of you with the systemic treatment of the burn patient. How do we prevent that circle of stasis from also becoming necrotic? Good fluid resuscitation. More on that in a moment. Let's talk assessment first. We've learned first degree, second degree partial, second degree full, third degree, fourth degree, right? Do you know what the burn center wants to know? Superficial or deep, and a narrative description of what you see. So, first degree burns are not what we're talking about. A sunburn is a first degree burn. First degree burns are not calculated into the total body surface area of major burns. Even someone who has a total body sunburn, A, got it slowly over time, and B, it's still a sunburn. So, just to be a responsible citizen to you, let's flash over the traditional classification that we all get tested on and we all need to know still. First degree burns are like sunburns. Move along now, little doggy. Or I'll see you after the next few patients. Superficial second degree burns injure us down to the papillary dermis, so basically at the germinative layer just below the epidermis. Deep second-degree burns get you right in the reticular dermis. Ouch. Basically, all of your skin is cooked. Third-degree burns injure you down to the subcutaneous tissue. You've burned through the skin and now you've got to the fat. Fourth-degree burns are down to muscle and bone. Now, you can remember all that for your boards and tests and your Jeopardy watching at home. It's great multiple choice generating content, but does it really help you at the bedside? Especially since in one wound, you'll often find multiple degrees of burn. Let's consider a more clinically oriented burn classification. Superficial or deep. In other words, is it a second-degree superficial burn or worser? Superficial burns will have blisters, and so will deep burns. But superficial burns will be moist and have hair follicles still intact. Deep burns will be dry. Hair will pull out effortlessly in deep burns. Superficial burns will hurt a lot. Deep burns may not hurt so much. Superficial burns will be pink or red and have still capillary refill. Deep burns will be white or mottled. There's no capillary refill for the deep burns. It's all cooked. Superficial burns, thankfully, will often heal within a few weeks. They scar very rarely and have minimal wound contraction. Deep burns will have several weeks to heal. They'll definitely scar and often will lead to wound contractions. Now remember, with all of your assessment, If the scald is in a, let's just say, suspicious pattern, especially if it's in a straight line, consider abuse. Children who are dipped in a steaming bath will retract their legs. So, in a non-abuse situation, maybe a distracted parent doesn't realize that the bath is too hot, and the child immediately retracts his foot from that hot water, and maybe a toe or two gets a first-degree scald. When you see second-degree burns to the feet, to the posterior legs, to the buttocks, just think what had to have happened to cause that. The child is wailing in pain, knees bent up into his body, and still the immersion happens. That's concerning for sure. Okay, look for other signs of abuse and get your social services involved. We do all this to characterize the wound and to get the extent of the burn. Now, let's talk about surface area. In adults, it's easy. We use the rule of nines, or what's also called the Wallace rule of nines. Parts of the body are either 9% body surface area or some multiplicative of 9. So your anterior thorax is 9%. Your posterior thorax is 9%. Your abdomen is 9%. Your lower back and buttocks are 9%. Your entire upper extremity is 9%, and your entire lower extremity is 18%. Since your head and neck is smaller than all of that, your entire head and neck is 4.5%, so half. Of course, we can always use the patient's palm as a reference, about 1%. Is it accurate? Well, for the most part. With obese patients, not that much. If you're missing an extremity or more, then of course, no. The point is not to do a geological survey, but to get an estimation. In children, you can see the trouble we'll run into immediately if we use the rule of nines on all ages. As an infant and small child, your head is much larger in proportion to your body. Your legs and arms are little nubbins in contrast to your torso. There has to be a better way to estimate as you get older. Well, there is. Thanks for asking. We use the Lund and Browder chart. Basically, the chart will have different values for the head and neck, for the thigh, for the leg, and all of these will change at ages 0, 1, 5, 10, and 15. Other parts of the body, like the chest and the abdomen, will stay the same in proportion. It's much too much for me to keep in my head, so the way I look at it is this. When I walk up to the bedside, my automatic mode is the rule of nines because it's easy to remember. I start my treatment and resuscitation. When the pain is controlled and I have a moment to document, to order ongoing fluids, or to talk with the burn center, I bust out that Lund and Browder chart and adjust my estimate for age. The real reason to use the Lund and Browder chart is for more accurate estimates for fluid resuscitation, as well as meeting criteria for specialty center management. Airway, got it. Breathing, on it. Circulation, are we doing it right? Now is the time to realize that there are multiple ways to become hypovolemic in a burn. First is the insensible loss. Just like your favorite food that is left in the refrigerator, if there's no protective cover, it dries out. Your skin is this amazing breathing organ that regulates your temperature. It participates in your fluid balance. It feels, it insulates, it protects. All of these things all at once. When 30% or more of your body surface is burned, the systemic inflammatory response begins. Complement is activated. Coagulation starts. It all leads to microvascular thrombosis, causing histamine and bradykinin release, which also causes more edema. Tumor necrosis alpha is secreted, which is a myocardial suppressant. In large burns, there's a rush of catecholamines, of angiotensin, vasopressin. All of those cause splanchnic vasoconstriction. Peripheral vasoconstriction occurs, and when the peripheral tissues, now that they're edematous and clotting, are getting worse perfusion, the area at risk dies, causing even more of a cascade. Now, there's also no physical barrier to prevent water loss. Vasoconstriction is not happening. Everything's in disarray. You're losing fluids. You have poor pump function. Almost completely gone is the ability to compensate peripheral vascular resistance. All right, convinced this is mostly a circulatory problem? Remember that when histamine is released, maybe some other neurohormonal regulators happen. All of those can also cause bronchospasm, respiratory compromise, whether or not there is any smoke inhalation. A tight chest also means decreased chest wall compliance, which also means worsening preload. Now, if you make it through all of this, you still have issues in the subacute phase with nutrition. The intestinal villi are all taken out. You have poor absorption, you have capillary leak, bowel mucosal injury, poor wound healing. You need nutrients to heal, and because your gut takes a hit, you get slammed with bacteremia as the bugs translocate across the bowel wall and into your circulation. Did I mention that you were a multifactorial shock state and poorly nourished, and now you're septic? And those are just the highlights. The good news is that a lot of this can be mitigated by a good resuscitation. And that's where you come in. There are various formulae for what the right amount of IV fluids is for both adult and pediatric patients. Cope and Moore in 1947 said, give 150 mLs per percent body surface area burnt and use 1/2 of that plasma and 1/2 of that crystalloid. Evans in 1952 said, give 2 mLs per kilo per percent body surface area and then maintenance on top of that. Batchelor in 1961 gave a range, but said use plasma and blood only. Baxter and Shires in 1968 were the first to say use crystalloids only and give 4 mLs per kilo per percent body surface area in those 24 hours. Now we're getting somewhere. In the 70s and 80s, there were others with different conclusions as to what the best fluid and rates were. This leads us now to the current two most popular formulae, the Galveston formula and the Parkland formula. With all respect to the folks at Shriners Hospital in Galveston for a wonderful formula, I think it works well for them for their inpatient service when the dust has settled. I say this because it's a bit complicated and requires calculating a body surface area in meters squared. So weight in kilos multiplied by the height in centimeters divided by 3,600, then take the square root of that. No. Seriously, though, it's just not practical, and the ED is fraught with opportunity for calculation error. When you have time later on, do all the calculations that you like. Maybe that's just me, but I'm guessing it may be you also on an off day. Anyway, enter the Parkland formula. Remember the Baxter and Shires formula just now? Well, one Dr. Charles Baxter worked in the 60s in one Parkland hospital within one University of Texas Southwestern Medical Center in a place some call the Dallas of Texas. The Parkland formula is 4 mLs per kilo per body surface area in a balanced solution like lactated ringers. You calculate that, then you give half over 8 hours and the other half over the remaining 16 hours. Remember that this is on top of the maintenance fluids. So, a 10 kilogram 1-year-old is burned with a 20% body surface area superficial burns, so second degree. 4 mLs per kilo is 40 mLs per percent body surface area, so that ends up being 800 mLs. You'll give half of it now, so 400 mLs you'll add over the next 8 hours, which means about 50 mLs per hour from Parkland that we add to our maintenance fluids. A 10 kilogram child would get, say, 40 mLs per hour in maintenance. So with Parkland, we more than doubled his fluids. It's so important to remember that the Parkland formula is not to calculate the burn patient's fluid requirements, but what he needs in addition to normal maintenance. By the way, some sources will say use 3 mLs per kilo per body surface area for children, which is fine, but those same references mention that children often need more fluids than adults. It's a little bit of a conundrum because, yes, children have a larger body surface area in relation to their weight. They're more spherical than cylindrical, but their skin is thinner. Their metabolism is faster, so take it as you'd like. For simplicity in the acute setting, I use the original Parkland of 4 mLs per kilo per percent body surface area, one half of that over 8 hours, and the other half over the next 16 hours. Let's practice just one more time. You have a 20 kilogram 4-year-old who has 10% body surface area burn. 4 mLs per kilogram equals 80 mLs times 10% body surface area gives you 800 mLs. The same amount of fluid for 2 different children with 2 different weights, but the difference is in the extent of the burn. Add that to his maintenance of, say, 60 mLs, and he's getting 100 mLs per hour, 60 from maintenance and 40 from Parkland. Just to be clear, this is all after you've resuscitated the child. If the child, let's say, that's 10 kilograms, the 1-year-old has a blood pressure of 70 over palp, you are going to give crystalloid. You're also looking to see if he has any other trauma. After all that is said and done, and his blood pressure is, let's say, 90s over palp, he's resuscitated, then you do your awesome calculation for all the maintenance things that you could ever want. Remember, first, it's normalization of vital signs. Then, monitoring things like urine output, which should be about 1 to 2 mLs per kilo per hour in children. There really isn't great data on how to balance the under-resuscitation of shocked patients with the other problem, with over-resuscitation. Stutchfield et al. In 2019 in the British Medical Journal did a systematic review looking at endpoints like urine output. The study protocols, unfortunately, were so heterogeneous that they couldn't come to a conclusion based on the existing published studies. For us, just remember, under-resuscitation is bad. Over-resuscitation comes into play, I feel, more as an inpatient, as the child slowly accumulates too much fluid over time. But what is too much? We don't actually know because third spacing is really the enemy here. Just because the fluid ended up in the third space doesn't mean the patient didn't need it at the time. What's the culprit? An interesting article by Osuka et al. In Shock in 2018 blames, are you ready for it? Yes, the Glycocalyx. All the rage in sepsis talk a few years ago, the Glycocalyx is back to get some credit or blame. You'll recall that the Glycocalyx is a fuzzy coat of glycogen, protein, and lipids that lines many cells. It's like a nice coat. It helps to keep us insulated from the dramatic changes around it. Think of chia seeds in water. Same idea and imagery. You're welcome. Anyway, the Glycocalyx lines the endothelial surface as well and does a pretty good job of regulating endothelial permeability. The Glycocalyx is negatively charged, and so is albumin. So the glycocalyx basically keeps albumin within the capillary beds in large part by deflecting it from the cell lining so that your albumin doesn't ooze through and cause more capillary leakage. In shock states like sepsis, there is a microvascular disarray and the glycocalyx loses its Teflon abilities, and so you get more and more and more ooze. We initially had more research on this in sepsis, and now we believe this is a similar pathophysiology in major burns. Speaking of physiologic disarray, and just like the example of sepsis or trauma, remember the lethal triad in severe burns: hypothermia, acidemia, coagulopathy. Burns, as we mentioned, are a trauma, but unlike standard multi-trauma that you can often detect on physical exam or radiographic studies, the multi-organ component in burns often is a smoldering one. Pulmonary, cardiovascular, metabolic, endocrine, and infectious complications creep up on you. In a prospective study by Sharon et al. In the Journal of Burns, they found that in patients with burns of 30% body surface area or greater, and those who also presented with or later developed the lethal triad of hypothermia, acidemia, and coagulopathy, they had an increased mortality of 67% versus those without the triad of 13%. Remember that the burned child is suffering from insensible fluid losses. Resuscitation and meticulous attention to labs and vital signs will help to mitigate this. Now, we've been talking so much about metabolic issues and triads and bradykinins and other fantastic beasts and where to find them that we can't forget analgesia. Remember that the normal dose of morphine is 0.1 milligrams per kilogram. You can always repeat it, but please don't underdose it. That 1-year-old who's burned, he's 10 kilograms, so he gets 1 milligram of morphine. The 3-year-old who's 20 kilograms, 2 milligrams of morphine or whatever your opioid equivalent is. Burns hurt a lot, and you would hate to be giving crystalloids for that tachycardia when all you needed was some good old morphine. The sequence of events should really be airway, breathing, circulation, pain control. It can be especially difficult, and it almost feels cruel to hold down a burned child to get an IV. I go to intranasal meds immediately. Intranasal fentanyl is fantastic for this. Another option is intramuscular opioids. One thing you can think about, if you have a little patient who's really suffering and writhing around and no one can get close to him, try intramuscular ketamine, 3 to 5 milligrams per kilogram intramuscularly. Now, this is, of course, 2 to 3 times the dose you would give IV, but don't be afraid. Ketamine's analgesic properties will help with the pain, but more importantly, will help to dissociate this poor child so that you can get the easiest IV ever. Let's recap our assessment. Airway. Was there an inhalation injury? Soot around the nares? Stridor? He who hesitates cannot intubate. Swelling happens from the injury, but also if we just wait and see, fluids from the resuscitation itself can third space, and then you're all toast. Breathing. Okay, maybe there's no indication for intubation now, but what's the oxygen saturation looking like? Why is it 93%? Are those developing pulmonary contusions? What do the lungs sound like? Is there wheezing? Remember those histamines and bradykinins? RALs? Alveolar injury. Or maybe all of that is deceptively well appearing, but wait, what kind of burn was that again? It was a house fire? Or it was industrial? There's lots of plastic involved, a prolonged extrication, CO2 poisoning, or cyanide poisoning from the plastics. Check a carboxyhemoglobin level. Greater than 10% in children is concerning. If greater than 50%, it's likely fatal. Think about all of the combustible chemicals that the patient may have been exposed to based on the context of the event. Aldehydes, ketones, organic acids. Be a detective. Circulation. What are the vitals? Do I have good IV access? Hopefully in areas not close to the burn. Remember that skin may swell or slough off. I've seen IVs popped out over time because the local edema displaced the end of the catheter. Remember, unburned skin is preferred, but you gotta do what you gotta do. Use ultrasound if you can. If you have to do a cut down, remember the saphenous vein. It's consistently anterior to the medial malleolus. You can even consider a great saphenous vein cut down in the groin. But before we get ahead of ourselves, always remember your friend, the IO. As an aside, if you have to put in a chest tube through burned skin, you have to do what you have to do, but consider a kinder, gentler, just as effective option, the pigtail catheter. Disability. Get a baseline GCS and neuro exam. You'll be glad you did, and you'll be asked about it multiple times. Do a great head-to-toe exam and look for other trauma that we may be missing. Exposure. Get that kid naked. There may be ongoing injury because of hot materials or insulation. Hopefully, if this was a caustic substance, the child had been decontaminated already. If not, do it. And remember, perform your own body surface area assessment. It's good to compare with others, but if you are doing the calculations and you are ordering the fluids and you are talking to the other services, then you do your own body surface assessment. What you give to the patient and where the child goes will depend on it. There's nothing worse than drastically changing your plan when you discover that your initial data was wrong. That brings us to whom do we transfer to a specialty burn center? This is a complex answer because it depends just as much on where you are in the world as where you are in your own country. Follow your protocols, but here is what the American Burn Association recommends. 10% or greater of second-degree burns. 5% or greater of third-degree burns. Burns to sensitive areas, like the face, eyes, ears, genitalia, perineum, feet, as well as those that may not heal well, like over hands or joints. Patients who have multi-trauma. Patients who have comorbidities, or any inhalation injury. Okay, the airway, breathing, circulation, you're managing it, analgesia, fluids, and you're getting the burn center online. What do we do with the wound in the meantime? Many centers will tell you less is more because they are very particular about how they manage the wound. Most will say keep the wound moist, clean, and covered, which means gauze soaked in sterile saline, wrapped and kept cool and clean. Many times you have to get the debris off or clean the soot off or just get a better surface for your clean, cool, soaked gauze or, truthfully, to assess the estimated body surface area burned. Wound changes are painful. You don't want to plant the seed of a possible post-traumatic stress for the child, especially since he'll need weeks to months of dressing changes, each one with a potential for mental trauma. Also, you don't want to cause further physical trauma, more irritation, more edema, or really muck around too much before the burn surgeons start their own treatment. These centers, as I've mentioned, all have their own particular way of doing things, and it doesn't serve the patient well to provide an elaborate, sophisticated wound dressing that you're very proud of and impresses everyone when it's just going to be taken down on arrival. We want the area cool, clean, and moist. Nothing fancy in the ED. Now, just to give a little bit of a shout out again to how important your skin is and how important that barrier function is, remember that the whole point of skin cells is to differentiate into keratinocytes so that they can start at, let's say, the stratum basale, just above the dermis, develop into a supportive reservoir of the stratum spinosum, so that they can enucleate themselves and be ready in the wings in the stratum granulosum, just behind the stratum lucidum curtain, so that they're ready to become mature squames that happily slough off with trauma, with friction, with everyday activity, because they're making more now as we speak. Bacteria that try to get into our system are caught up in the dying cells, and they get shed. They get blocked from entry. When your squames are gone, as in a burn, bacteria readily enter. When your developing strata, your basale, spinosum, granulosum, and lucidum are burned off, you are particularly vulnerable now as well as into the future until whatever is left can regenerate for you, or you get a skin graft, or just live with a badly scarred and less functional area. Over time, contractures form around joints, further limiting function. This is all just a reminder to us that even after we get our patient through the initial evaluation and treatment, what we do initially will have echoes in the recovery phase over weeks to months to years. After resuscitation, after analgesia, after all is settled, try giving low-dose ketamine before the wound change. If the child is really having a hard time, you may think about giving the procedural sedation dose and considering wound care as the procedure. In children who may not need all of that, you can try viscous lidocaine about 20-30 minutes before. Remember, it's water-based, so it also feels cooling. Apply the viscous lidocaine to the burn, you wait, and then you wipe it off. You can wipe off all that debris with some dry gauze. Likely you'll get the wound cleaned up and the pain controlled. Remember also to check tetanus status. Most young children will be up to date, but always ask. These are tetanus-prone wounds. No prophylactic antibiotics are needed. Just a few things to remember. Who needs an escharotomy? Children with circumferential burns. The edema that pushes up against the cooked dermis is like when you put a sausage in a microwave. They plump when you cook them. But more importantly, you get poor venous return and worsening circulatory status. Also, another indication for escharotomy is poor tidal volume. You may have to perform an escharotomy on the chest. Go through the eschar itself, just to the healthy tissue, no deeper, and no need to cut into the fascia. Now, this is never really an emergency to do, meaning that after we've dealt with all of these other issues, you have time. You have minutes, maybe an hour or hours. My point is that this is such a low-frequency, high-risk procedure that we should really look it up in a reference. The gist of it, just for conversation, is that you cut a box pattern on your chest and seams down your legs and arms. But careful. When you're cutting through charred skin down to the outside of the arm, don't cut the cephalic vein or down the medial aspect and bag the ulnar nerve. There's a quick reference image in the show notes. But basically, you start the incision at the clavicles and extend it down the anterior axillary line inferiorly to the depth of the subcutaneous layer. You end up with 2 long lines down each anterior axillary line. Now, we connect them. You connect cephalad with a curved incision below the clavicles, resembling a low necklace. Another transverse incision is made at the border of the thorax and abdomen. That procedure is often called the Roman breastplate because the result are 2 vertical and 2 horizontal cuts that resemble a soldier's armored breastplate. The idea is to free the anterior thorax from the edematous constriction so that there is improved tidal volume and oxygenation ventilation. Again, there is almost always time for this, and it's almost always done in the OR. But if you're stuck somewhere without help, maybe you're in a rural setting, maybe transport is not available, maybe this is a disaster situation and your resources are very slim, do it. If you have respiratory compromise or circulatory compromise, use antiseptic and good old bright lights and cold steel. A clean scalpel is your friend. If you're stuck taking care of this patient for hours and you need a meticulous escharotomy, you can also use electrocautery to stop those pesky little bleeders. Back to our patients. The 3-year-old girl with multiple extremity burns, 30% in your estimation, she did well after transfer and after a prolonged hospitalization. The 5-year-old who was coughing but otherwise not complaining was intubated just in time. His critical care course was complicated and tortuous, and a year later he is still requiring ongoing care. The 2-year-old girl who made her displeasure with you known and possible multi-trauma was investigated and went home after a few days with local wound care. You were ready for each of them, and your facility with these major burns helped them to survive the insult and have a much more positive trajectory in the long journey of recovery. In summary, major burns need major attention to meticulous critical care. The patient is usually worse off than you think, or soon will be worse off than you think, so anticipate decompensation. With one trauma usually comes another trauma, so look for the injury you're missing. For percentage body surface area, use the Lund and Browder chart for children and the rule of 9s for adults. Parkland will tell you 4 mLs per kilo per percent body surface area. You take that and give half over the first 8 hours, and be sure to add that hourly amount to your hourly maintenance. Analgesia: early, often, intranasal, IM if you need it, IV as soon as possible. Burn center criteria are 10% for second degree, 5% for third degree, and any burn to the face, hands, feet, perineum, genitalia, or over joints. And finally, these patients are sick and you can't do it alone. Get your burn surgeons involved or the transfer process started early. Or if it's really just you for the foreseeable future, buckle up and reassess. You are now treating a patient in hypovolemic, distributive, and cardiogenic shock. Oh, and also there's another 20 people in the waiting room who just checked in. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.